you and request you, those who are outside Kathmandu, is that if you are interested to start psycho-oncological services in places outside Kathmandu, we are here to help you, and we have lots of experts who can guide you. We'll do our best to guide you through the process and even link you with the places or centers. So with this, I would like to hand over to you, Swikriti, to go ahead with the session. Thank you.
Okay, thank you, Dr. Risha. So as we start today, let me just brief you about today's session. So today with us, we have two experts, and the topics that they will be discussing are related to survivorship in cancer care. So when we talk about survivorship in cancer, it refers to a period after cancer treatment, when individuals are considered to be in remission or even cured. So it is important for psycho-oncologists to understand that this phase of survivorship, because cancer survivors often face a lot of psychological challenges, including, common disorders like anxiety, depression, and most commonly we can talk about fear of recurrence that stays even after treatment or even after reassurance, when the doctors have reassured them that there is less chance of recurrence. So, as a psychiatrist or psycho-oncologist, we can provide crucial support in addressing these emotional challenges to these patients, when they're trying to get back into their lives. So, our first presentation today will focus on one of the very most common challenging experiences for cancer survivors, which is the fear of recurrence. So, to guide through us through the embracing acceptance of fear, as I say, please join me in welcoming Koen Völker, a psychologist in psycho-oncology from the Helen Darling Institute in the Netherlands. So, Mr. Koen has over 2 decades of rich experience in this field, and he has authored 3 books and he hosts a podcast on fear of cancer recurrence. He has been also connected with Bhaktapur Cancer Hospital since 2007. So he will be discussing on a very interesting program called the RITTA program that he will elaborate further, and how radical acceptance can help individuals manage this persistent fear. So, Mr. Koen, yes, over to you. Yes.
Okay, so thank you very much. So thank you for this nice introduction. Let me share my presentation with you all, and thank you for the invite for talking about this topic. I think you see now this embracing acceptance of fear. Is this correct? Yes.
Yes.
Okay. So you can see here my email address also and my website. Together with Dr. Rishav, we've created the Psycho-Oncology unit in Bhaktapur, but you can also find me on LinkedIn if you want to connect with me. Now, most of my work, clinical work, has been around fear of cancer recurrence. And today we're going to talk a bit about one part of this called how can we accept the uncertainty which is inherent in the cancer survivorship. I'm going to talk a little bit about a program which I developed called RITTA. Maybe we'll share 2 interventions if we have the time. We'll have some short time for questions at the end, 1 or 2 questions. Then Sophia is going to take over, and at the end we're going to have more time for questions. And in the chat box you can also put some of your questions in there. So this is me, Psycho-Oncology in Nepal, with some of the people from the Bhaktapur Cancer Hospital a while ago. I didn't have a beard, as you can see, yet. This is more recent with Dr. Rishav and Regina, the psychologist for the Psycho-Oncology Bhaktapur, where we established the first government hospital psycho-oncology unit. Now, these are some of the questions that have been put forward for today. And what I made yellow, this is partly what I'm going to address in the lecture, in the presentation that I'm going to have today. So for instance, how does comorbid or past history of psychiatry disorder affect fear of cancer recurrence in cancer patients? Well, one of the things I can already say is, of course, there's overlap if people have in the past panic disorder or post-traumatic stress symptoms. But we also see that there is a difference between the two. Not everyone who scores high on fear of cancer recurrence has a panic disorder or anxiety disorder. So there is overlap, but it is not the same. And I hope that today, after my presentation, we already addressed some of these other questions about what are the things that are often misunderstood about fear of cancer recurrence in psycho-oncology. Now, this is, I think, the most important slide that I'm sharing today. If I want you to remember one thing, I want you to remember this quote from Dr. Gabor Mate. And he's saying, safety is not the absence of danger, but the presence of connection. And I think this is one of the things what we can offer as psycho-oncology professionals is that, of course, there is danger of recurrence. Of course. We can ensure that people know the statistics, that they know the good prognosis. But of course, many people know that if you have had cancer in the past, then you can get cancer again. If you had an accident in the past, you can get an accident again. So to actually tell people that they are safe often doesn't give them safety. But to offer our connection, our social connection, to see that we hear them, that we see them, that we can offer a sense of guidance is often a way to limit some of the fear of cancer recurrence. So remember this quote, the most important quote of what I'm sharing today. Now, I will share a little bit about acceptance and fear and how those two are mutual. Now, if we look at fear of cancer recurrence, of course, this is a normal problem because many people have it. Now, researchers and clinicians have made 4 criteria to see clinical fear of cancer recurrence mean that the fear of cancer recurrence is very high, which means that people are very preoccupied. It's in their mind a lot. They might have sleeping difficulties because they worry a lot. It is there during a big part of the day. And they might be hypervigilant of bodily symptoms. So they might feel something in their breast and think, oh, maybe this is a breast cancer recurrence or not. And these symptoms of fear have a certain amount of severeness, and at least for 3 months. Now, you will get this list, the Fear of Cancer Recurrence Inventory short form. We use this through the whole world and in Holland also, and I help to translate it into Dutch. You see here on the left 9 criteria, how to measure how high fear of cancer recurrence is. And if you measure it, you could see 13 or higher is mild to medium, and 16 or higher is medium to severe, and 22 or higher is severe to very severe. Now, of course, many of our nurses and doctors don't maybe have the time to use this list. So another questionnaire which is used is the fear of cancer recurrence 1 item. And in the 1 item, you just ask one question to the patient, and it says, how high is your subjective experience of fear of cancer recurrence in the last period from 0 to 100? So just from 0 to 100. 100 is maximum, 0 is totally not. How high have you been on fear of cancer recurrence in your experience for the last period? And then if we say 45 or higher, that correlates quite well with the fear of cancer recurrence inventory short form. So that is, for instance, nurses and doctors can use this 1 item. How high is your subjective experience? 0 to 100. And then if you're at a psychosocial clinician, a psychologist or psychiatrist, you can use this list, and you will get it afterwards after this webinar. Now, if we look at, if we've used that list around the world, we can see how high the percentage actually is. You see that more than 50% of the people who have a good prognosis, afterwards, they still have mild to medium fear of cancer recurrence. And for 19 to 30%, these are actually very high. So they have a lot of impairment about the fear of cancer recurrence. Now, one of the things that I highlighted here is that the percentage for fear of cancer recurrence, or the worry or the stress that they have that it might happen again, is just as high in family caregivers as is for the patient. There's been some research of Ben Smith and colleagues in 2022, which says that these numbers are quite the same. The numbers which are higher is that it's for young people, adolescents or young adults. So that's until 19, until 35 or 39. We see the percentage is actually double so high. So the young people with cancer, they often are much higher. So we need to address that for young people, but also for the caregivers. For instance, one way to address it is that I often say to my clients, many of my other patients have worried that the cancer might recur. They don't want to think about it. They want to be optimistic, but still they have in the mind this thought, what if the cancer might recur? Do you also have these kinds of thoughts? And if the patient says, yes, I also have these kinds of thoughts, then you can ask, can you tell me a little bit more about it so that I can help you navigate these worries, because they're very normal. And as you can see here, the percentage are so high. So most of the people with the good prognosis have such high numbers. Now, we also see that people who are high on fear of cancer recurrence, they visit the hospital much more. So we have actually two groups who are higher on fear of cancer recurrence. One is the group of the people who avoid. They come very late at the hospital because the fear of recurrence is so high. These are the avoiders. And then we have the people who want to give safety. They want to get reassurance for us, but they don't get reassured so quickly. So they want again reassurance and again reassurance. So they visit the hospital much more often, which means that the hospital pressure is also higher. Now, I'm not sure if in Nepal it would be the same. My guess is that the avoidance group might be even higher in Nepal. And also because we know that from many people with cancer, they visit the oncology hospitals often very late, and we would like that they visit them more quicker. Now, there are a couple of articles on the relationship between acceptance of cancer and illness and distress. You can view them on the internet. Now, one of the things that we know, we can ask, is there actually a relationship between acceptance and fear of cancer recurrence? And the answer is yes. So many people who score high on acceptance of illness, it is part of life. It is very unpleasurable. It is maybe very sad, but this is also part of life. I accept it. Then often we see people score quite low on fear of cancer recurrence, and the other way around. So people who score high on fear of cancer recurrence often score low on acceptance. Unfortunately, we also see that people who score low on acceptance make statements like, illness sometimes makes me feel like I am burdening my family, or that I'm burdening my friends. What is my added value to society or to my family? So people can get depressive thoughts. We also see that people who score high on fear of cancer recurrence often score lower on meaningful life. So if you can help people get more meaningful life goals, what can you add in your family? Maybe the many things you can't do anymore because of the fatigue, but there are many other things that you actually can do. And if you do that, you can see that you can also lower some of the fear of cancer recurrence. Now, this is a new way of looking. A colleague of mine is at the University of Tilburg in Holland, and she uses a network model. So on the left, you see anxiety, and on the right, you see acceptance. So in the past, we have seen anxiety disorders as syndromes. People with an anxiety disorder, they have these kinds of symptoms, and people with depressive disorders, they have this kind of symptoms. But in psycho-oncology, we'll actually see that all these symptoms influence each other. Many people who score high on anxiety often score also high on depression. Now, this is research with with 342 cancer patients. And for 3 weeks, we asked them to fill in an app 5 times a day. And then we see what the relationship is. You can see there is a blue relationship, which means high on depression, high on anxiety. And if there's a red relationship, it means a negative relationship. So for instance, you see here helplessness, people who feel helpless, don't know what to do. And here you see acceptance. If People score high on helplessness, they score often low on acceptance, and the other way around. Now, in the past, for psychological therapies for anxiety disorders, we tried to lower anxiety. But of course, anxiety in cancer care is very normal. So this was not always very successful. So what are we doing now is not only addressing anxiety, but also addressing some of the things that are in relationship with the anxiety. For instance, depression. Can we help people to feel more that they have meaningful goals in life, even though they had cancer, that they still have added value, that they still feel good about themselves? On the other way around here, if we can promote acceptance with patients, then we can also lower probably the anxiety levels a little bit. So this is interesting to see also because in this model, we not only see the psychological symptoms, you see here this on the left, but we also see here, for instance, physical symptoms. If you have physical symptoms, because you have had chemotherapy, you might be very fatigued. If you're very fatigued, you might feel very much helpless. So we see there's a strong line between the two of them. And if we help people to kind of make this kind of network to see themselves more clearly, we have much more things that we can do instead of just focusing only on the anxiety. So if we look at acceptance, and we see that acceptance can be very much emotion-focused coping, meaning-making coping, but it's also that if people score higher on acceptance, it's not only, okay, I accept that I have had this illness, I accept that I have gone through this period of radiation therapy, but also that the echo of radiation therapy, like fatigue, or the echo of having cancer, like uncertainty and fear, affects you. People who are survivors of the cancer often have these echoes of fatigue and for uncertainty for the future. So if we can help people to actually navigate some of that feeling that their body gets more aroused because of the fear. You know, fear doesn't create cancer. Also good to do myth debunking. Myth debunking means, what do you think about the fear? And then many people think, oh, I am so afraid, and probably if I'm so afraid and aroused and I have high blood pressure because of the fear, maybe the cancer will recur much more quicker. And we know this is not the case. Yes, if you start to smoke a lot of cigarettes, if you're afraid, this might not be good for maybe lung cancer in the future. But fear itself doesn't create cancer. So this is good that we have these stories with our patients about this. Now, I also write here, acceptance is not like a state, you've accepted or not accepted. Accepting is more something that you do every day, accepting that this is your experience right now and that it might be a sad experience as well. So this is about acceptance and commitment therapy from Russ Harris, an Australian trauma-focused therapist. He says, the most difficult thing about the acceptance and commitment therapy is accepting painful experiences. Getting cancer is a painful experience. Having to, deal with uncertainty about the future is painful. So as psycho-oncology counselors, we should not try to make their experiences less painful, but we try to give them connection, to give the space that this is actually painful, this is actually difficult, and we can make the space for you for these feelings. Because if you're not making space for these feelings, then you're going to suppress feelings, and that will not be very healthy for your mental state. So I've created a 5-step program to deal with fear of cancer recurrence. It's called RITTA. You can find it on Spotify, or you can go to my website, koenvölker.com, and you can get the audio. So for every step, I have 40 minutes audio, and you can listen to what I say about what you can do in each step. There's also a book you can get on Amazon. So what is this 5-step program about? So the first step is, can we recognize fear as fear? Many of our patients who are very afraid might be very angry on the outside. And we might think, why are you so angry? but they're not really angry. They're very afraid. They're very fearful. So if we can address them as, are you worried? Do you have stress about what's going on? Then we can help, tell them, normalize these kinds of feelings, that as we've seen, more than 50% of the people have fear of cancer recurrence, even if they have a good prognosis. So this is very normal. And we can give them psychoeducation. We can tell them, if your brain thinks that you're in danger, what does it do? It pushes stress hormones into your system, cortisol, adrenaline. It makes you want to fight or flight. It gives you a stress feeling, because if you're really in danger, to have stress is very helpful. You can run away more fast, or you can fight more with more strength. So if your brain thinks, oh my God, I feel something in my breast, the cancer is back, the stress hormones go up because your brain thinks you're in immediate danger. Now, of course, your brain, after 3 to 30 minutes, realizes, okay, there's not an immediate danger, so your stress hormones go down again. But you feel all this arousal in your body. This is very normal. So I ask people, how do you actually feel when the fear comes up? And then they tell them, I feel warm. And why do I feel warm? Is this normal? I feel my heart is going like this. I think maybe I'm going to have a heart attack. And then I can tell them, you're not going to have a heart attack, but your heart rate is going up, your blood pressure is going up, because your system is helping you to get aroused, because your brain is thinking you're in immediate danger. Now, if you're in immediate danger, it's very helpful to have high blood pressure, because the oxygen and the energy goes more quickly towards the organs that you can use for fighting or flight. So psychoeducation. Fear is very normal. It's not, you don't get anything. You don't get cancer from fear. So this is recognizing fear when it's there. Some of the men that I work with, if I ask them, are you afraid that the cancer might come back? They say no. If I ask them, are you not relaxed? Or you stressed? They might say, yes, I'm stressed, but I'm not afraid. Okay, fine. Then we're going to talk about stress. So use the words that are meaningful for your patients. Now, the second step, investigating, is if we know that our patients are afraid, we can help them address this fear. What are you most afraid of? If the cancer would come back, what are you most afraid of? Plus, what do you actually hope if the cancer would come back? So to actually investigate this kind of fear, address this kind of fear, so people can get more into the details of this kind of fear. So if people know what they are actually afraid of, and they know what they actually hope, of course you hope that the cancer doesn't come back, but if it would come back, what do you actually hope for? And if they're not sure, then of course we're going to offer our support. We're going to say, even if it would come back, we're still here for you. We're still here for you. We're making connection. You're not alone. We're going to do everything that we can to help you and your family. Now, the third question is talking. Do our patients actually talk about fear and worries? And how do they talk about it? And are they talking about it in a meaningful way? And can we help them to talk about it, give words to what they feel? And the fourth step is about, what do our patients do when they get afraid? If they are very afraid, are they ignoring the fear? Or are they drinking alcohol to sedate them? Or are they going to go on the internet to look on the symptoms that they have? What are they doing, and how effective is it in the short run, and how effective is it in the long run? What do they do, and how effective is it? And then the last step, not the first step, the last step in this program is, can we talk with people? What do you find the most difficult to accept about this illness that you're having? What do you find the most difficult about the uncertainty of the future? And how can we build kindness and build compassion with our patients? Because many of our patients, they're so hard on themselves. When they're stressed, they get angry with themselves. They don't want to be stressed, but their body makes them stressed, because their brain gets them into a danger zone, because they think, oh my God, maybe the cancer is already back. Maybe my family is going to go bankrupt if I get the cancer back again, and I don't want my family. So you get worries. So to talk about these kinds of words is very helpful in making them accept. Okay, so, but this, of course, is difficult because working with uncertainty is difficult, both for us as clinicians, as doctors, as for our patients. Not knowing the future is easy if the future looks sunny and bright, but not knowing the future is much more difficult if we are in a difficult situation like a cancer survivorship. Just like Gillian is saying, you know, you might have had a plan about the future and the cancer is turning this plan around because you don't know what will happen in the future. Some people say, you know, people want us to accept it, but I cannot accept it because, you know, there's so much stress and people want us to move on with life, but it's so difficult. Let them talk about the difficulty. Let them talk about their stress. This is helpful. Talking is helpful, and giving them new perspectives on how to work with this difficult. Now, of course, there are many things that we can do to promote acceptance in fear of cancer recurrence. Now, I think I'm going to go into the practices another time. I just want to highlight one of these practices, and this is called, this is a solution-based exercise. Here on the left, I'm going to ask people, what do you associate with accepting and acceptance? So people might say that I feel peaceful, that I feel calm, that I can embrace it, that I can tolerate it. So all these different words I put on the left. And then I say, okay, if we see acceptance not as a dimension, which goes from 0 to 100, how much acceptance do you feel for your illness and about the fear of cancer recurrence? How much do you accept that your mind is worried often? And then we can say which of these words are higher, like, you know, embracing fear, and which are lower, like tolerating fear. And then if we have this list with our clients, and we can say, where are you right now on this list? Are you here or here? And then if they say, I am here, I'm accepting 30%, okay. How would you know that you would accept 40%? What is the difference between 40 and 30? And then people might say, well, if I'm at 40%, I'm not fighting myself. I'm not so angry with myself. I am a little bit more calm. And then I'm going to ask, oh, when have you been most calm in the last week? So these are all the exercises. It's also in my, I'm not sure if it's in my book, by the way, but I can talk about it another time. So what does the word accepting mean to you? We can ask our patients, what is the most difficult to allow? Nowadays, I use more the word allowing than accepting. People not always like the word accepting. So allowing is for many people a better word. And what supports acceptance. And I think I'm going to skip this second exercise. One of the things that is very important in acceptance and radical acceptance is kindness and compassion. You know, our patients can be so hard with themselves if they feel stressed. They might get so angry with themselves. They might get angry because they've had cancer. They might be angry because their family is putting finance into their health and they don't want that. They want to put the finance something else, but the family does it anyway because they love them. So to have a sense of kindness and compassion, to find a soft way of inner dialogue. And we can be that soft talk. We can be that voice of compassion and kindness. And if we talk with kindness and compassion to our patients, maybe they can talk to themselves with more kindness and compassion. So actually, I like this quote, maybe the opposite of fear is not courage, but maybe it's compassion. And maybe suffering also gives birth to kindness and compassion if we can turn towards it with an open attitude. So, as a summary, accepting matters because it does have a relationship with fear of cancer recurrence and meaning in life. It's something that can be practiced, and we can help our people, our patients, to practice this. But non-accepting can be problematic because people are kind of in fight with themselves the whole time. It also can be very hard because if we give people more allowance that this has happened in their life and this is still affecting, and maybe it can happen again, it might give a lot of space for grief and sadness. And if we can meet the sadness and the grief of our patients, we can help them process some of this difficult material. So I think these are some of the things that that we can help people with, and especially if we go slow, because accepting is a slow process. I find myself in my life, difficult experiences, difficult to accept and difficult to allow. So if you have like cancer, I didn't have cancer, but I think I will wrestle with it also, even though I'm a psychologist and I know I should accept it, but it will be difficult for me as well. So taking time for this as well. So thank you very much for your attention. Again, this is my email address. Thank you for BANC for giving me the space for this. I will now stop the sharing of my presentation, and maybe if there's one or two. Oh, I think I am overdue. Okay, so I'm giving the space. Sorry, Sophia, I was a little bit late. My apologies. I'm giving the floor to you right now.
Thank you, Coen, and thank you for a really succinct and interesting presentation on such an important area of psycho-oncology practice. I appreciate that. I'd like to thank Dr. Richa for the invitation to present as well. It's lovely to be here and be with you. And I see this as a conversation between colleagues. I'm sure a lot of you will have experiences of relevance to share for this. So just while my PowerPoint's being brought up. Thank you so much. Okay, so just to introduce myself, my name is Sophia Wooldridge. I'm a senior clinical psychologist and I work in a psycho-oncology service in a public hospital in Newcastle, Australia. Okay, next slide, please. Thank you. Because I work in a public health service and I'm Australian, it's important that I start my presentation by acknowledging the country that I currently am on. So I'm speaking to you from the country of the Awabakal people. That is the Aboriginal community that own the land that I'm on, that has never been ceded through the colonisation process. And I'd like to pay my respects to the elders of that community. Thank you. Next slide. Just to give you some orientation of where I am, this is a map of, as you would probably recognise, New South Wales, one of the states of Australia. I'm speaking to you from the city of Newcastle, which is 120 kilometres away north of the Sydney Harbour Bridge. The part of New South Wales that my health district covers is called Hunter New England Local Health District, and it's the section in yellow in the map that you can see there. My health district, in terms of land mass, is about 90% of the size of Nepal, and we have about the equivalent of 3% of Nepal's population. So we have some different challenges in terms of how we provide cancer care here with our population spread over a much greater geographical distance. Next slide, please. I thought I'd start with just a basic definition of menopause and perimenopause, just so that we all start off on the same foot. I'm not sure if there's some people joining our presentation today who are not medically trained. I myself, as a psychologist, have no medical training, so that's the space that I speak from. So I'll just leave you to read through those definitions. As you know, menopause is generally defined as when a woman has had 12 consecutive months without a period, and perimenopause is defined as the period of time leading up to that. So in the Australian context, that's usually understood to be about 5 to 7 years preceding menopause. Next slide. So one of the aspects of the situation I'd like to bring to your attention is that menopause in cancer care may be a slightly more salient issue in Australia than it is in Nepal. That's because, as you can see, prostate cancer and breast cancer are our two most commonly diagnosed cancers here. And as you know, survivorship and mortality rates have improved a lot for both of those cancers. That means that we have an ever-growing number of Australians in the community who have surviving longer after having endocrine-related treatments for their cancers. And obviously, women who've had breast cancer or ovarian cancer fit in that category. So my understanding in the Australian context is managing the effects of endocrine treatment in cancer care is a bigger percentage of a medical oncologist's workload possibly here, just because more people with those cancers are living longer. Thank you. Next slide. I'm sure this information won't be a surprise to you. This is some of the long-term health risks of early menopause for anyone, regardless of why that early menopause has come about. And in terms of cancer survivors, certainly early menopause, so there is some research emerging to demonstrate that it is an indicator for poorer quality of life and for long-term morbidity. Next slide, please. The symptom burden, some of the symptoms that cancer survivors can experience when they have menopause resulting from their cancer care are vasomotor symptoms. That's probably one of the issues that women talk the most about, is the hot flushes and night sweats. That can contribute to sleep disturbance, or sleep disturbance can occur without hot flushes. A range of GSM symptoms, and fatigue and reduced quality of life. Next slide, please. In terms of the psychological and cognitive effects of menopause occurring within cancer care, mood disturbances are common. As you might know, anxiety and depressive symptoms particularly can escalate. And women often talk about having cognitive complaints. That has traditionally been referred to as brain fog or chemo fog. As you know, in the cancer space, that's now referred to as cancer-related cognitive impairment. I'll speak about that in a moment. But women without cancer also describe experiencing cognitive effects as a result of their menopause process. An example of the complexity of this issue is this quote, and this is about obviously women who don't have cancer, but generally speaking, surgical menopause before the age of 45 is linked to increased risk of dementia and cognitive decline. So the area is complex. Next slide, please. So just to remind us all about why cancer treatment-induced menopause might happen, there are a range of ways that standard cancer treatment can impair ovarian functioning. It can be via chemotherapy, endocrine therapies, by oophorectomy, or by pelvic radiation. And we'll just step through those quickly. Next slide, please. So surgical menopause obviously is defined by both ovaries being removed before biological menopause has occurred. There is some research emerging to suggest that whatever mood impacts and cognitive impacts are going to result from that process may be evident by 3 months and is unlikely to get any worse after that. We're all aware that not everyone who has surgical menopause does so due to cancer. There are a range of reasons why women might have both ovaries removed, and that includes the category of people who have been found to have a genetic predisposition for cancer, who have prophylactic oophorectomy, such as women with BRCA. Next slide, please. In terms of the medications that are used in cancer care that can induce menopause, some forms of chemotherapy and immunotherapy have been found to have a higher risk of inducing menopause. Obviously, aromatase inhibitors and ovarian suppression medications. These medications, some of these medications are designed to induce menopause within 24 hours and are often prescribed for 5 to 10 years after a cancer diagnosis. And it is common for women having chemotherapy for a whole range of cancers, whatever the cancer. It's not uncommon for women who are having chemotherapy to have their periods cease. And the rates at which that occurs is affected by the type of treatment. Next slide, please. Radiation can induce menopause, as we know, as you can see in the diagram there, just a reminder of what transportation surgery can look like to try to sometimes move the ovaries out of the way if radiation is going to affect that area. It's not just gynecological cancers where this can occur, but also some anal cancers and rectal cancers. Next slide, please. Treatment-induced menopause is sometimes a bit loosely used as a term. Sometimes people use it to refer to medically induced menopause, but generally treatment-induced menopause is meant to refer to menopause that's occurred as a result of cancer treatment. And it's sometimes impossible to tease out which aspect of cancer treatment has contributed to that. And some symptoms of treatment-induced menopause do not present immediately after that form of treatment. So it's sometimes impossible to say. Next slide, please. And obviously, when a cancer patient's experiencing menopause, it's one of many challenges that are occurring for them at the time. So if you think about how often our cancer patients experience those symptoms I've listed there, it's so common for people undergoing cancer treatment to experience fatigue, to experience cancer-related cognitive impairment, sexual dysfunctions and sleep difficulties. And these symptoms occur in the context of a whole lot of grief and loss and psychosocial challenges as well. So obviously it's very difficult to tease apart when these symptoms appear. To what extent is this due to menopause, treatment-induced menopause, and to what extent is it to do with other aspects of cancer care? Next slide, please. Just a reminder, a bit of a visual about how hormone levels usually vary for women. So on the left there, obviously, you've got a normal chart for someone who's premenopausal over a couple of months. In the middle, that's what it might look like when someone's perimenopausal, and then on the end, what it looks like when women are postmenopausal. Obviously, some of the medications, endocrine medications that women are given through cancer care, they skip that middle bit of the frame, right? They go straight from premenopausal to flatlined. So it's not the same as a standard menopause experience. It's not like just a normal menopause, but faster. It's a different process. Next slide, please. And diagnosing menopause after cancer treatment is difficult as well. As I mentioned, 70 of women who will have their periods cease as they undergo cancer treatment, 70% of them will have menstruation reoccur within 2 years. This is a recent proposal about how this might be measured in cancer care. As you can see, this really important researcher, is proposing that for women undergoing breast cancer treatment, that should actually be 30 months, not, for most other women, it's 12 months without a period, and that's classed as menopausal. But, perhaps in the cancer space, it needs to be 30 months. We do know that cancer patients who don't have their periods return report lower quality of life years later. Next slide, please. So which cancer patients are most likely to have treatment-induced menopause? Breast cancer patients, obviously, but we should also keep in mind ovarian cancers as well. Particularly ovarian cancers, they also have the radiotherapy radiotherapy increasing their risk of menopause too. For women who have BRCA1 or BRCA2, the current recommendation is to have surgical menopause induced by the age of 35 to 40 years. So that's a lot of women. There's an ever-increasing number of women who have that occur. And again, anal and rectal cancers are important. Women who have stem cell treatments, stem cell transplants, the rate of induced menopause is up to 80% for that cohort. And that's a cohort we don't often consider when we think about treatment-induced menopause in cancer. We really need to engage hematology in this discussion as well. Next slide, please. So I'm sure you're all aware of this, but the options for giving hormone-related, like HRT, to women who've had endocrine treatments as a result of their cancer treatment, it's generally not recommended. There can be some options for some patients, but generally contraindicated. Next slide. These are some of the other medications that are prescribed to women to manage menopause symptoms when they're not able to take HRT for whatever reason. If we look at that list, I think we can all imagine the consequences of some of those medications on women's mood, particularly Catapres, for instance. These are anti-epileptic medications that are sometimes used. Some antidepressants, as you know, can't be combined with different aspects of systemic treatment. So it's not uncommon for women when they commence on an endocrine treatment after breast cancer treatment that they have to switch up and change from one antidepressant to another, which can be an additional challenge. I'm sure we could all identify impacts that these medications might have on women's mood. Next slide, please. In terms of non-pharmacological treatments, CBT still has the strongest evidence, particularly for vasomotor symptoms, and can have positive impacts on sleep and some depressive symptoms. There's some evidence for hypnosis, acupuncture, yoga, mindfulness-based stress reduction. There is emerging evidence of the importance of ongoing exercise in this space. As we know, ongoing exercise for cancer survivors can be just so effective in so many ways. Next slide, thanks. Just want to speak very briefly about this. I promise I'll only give this 60 seconds. The issue of women who have ADHD, who then have cancer and then experience menopause as a consequence of their cancer treatment. We have no evidence about what the impact of having ADHD is for women when they experience treatment-induced menopause. But we do know from other research that lower estrogen levels are correlated with more ADHD symptoms for women, and that when women's estrogen levels are lower, their stimulant medications are less likely to be effective. So these are issues we need to keep in mind, I think. Next slide, please. So some of the questions that leaves me with is, particularly in Australia, many women with ADHD are still undiagnosed. And in terms of how research has been conducted to develop the current concept of cancer-related cognitive impairment, if you look at the meta-analysis, women who have had breast cancer are really strongly represented in that research. And it just leaves me wondering, to what extent has our current understanding of CRCI actually been influenced by the experience of women with undiagnosed ADHD who are experiencing cognitive challenges as a result of their menopause process? Next slide, please. Okay, what can a psychologist do? Next slide, please. So in terms of assessment, there's very little evidence on this, I'm sorry to say. So two of the measures that are most commonly used in Australia are the MENQOL and the MENOD. The MENQOL has been used in Thailand with breast cancer survivors, which is great. I could see no studies of the MENOD used in cancer with women with cancer. The Australian Clinical Innovation Evidence Brief supports the use of the PHQ-9, which could be useful. I would suggest there's evidence to say that the DAS21 is not ideal for cancer patients, and ironically that the DAS21 is the most used measure for Australian women who are undergoing treatment at specialty menopause hubs in the public system. My take is that I use both the MENQOL and the MEND, and I can send reference links around for both those measures. They can both be useful in clinical assessment, but there's no point in scoring them because those measures aren't normed with cancer survivors. Next slide, please. I would say that managing menopause symptoms is really important for patients, cancer patients. We know that women on endocrine treatments who have menopausal symptoms treated are more likely to see out their cancer treatment as suggested. And there is some evidence for group CBT for women who've had cancer treatment who are experiencing hot flushes and night sweats. Next slide, please. I would suggest that while evidence emerges, the best way to proceed is to use the most evidence-based interventions for women with menopause, the psychological interventions for those symptoms. But we need to be open with our patients about the limitations of the science, and we need to put more effort into continually assessing whether our interventions are effective. Next slide, please. So I'm just going to quickly float. And again, I'm very happy for everybody to have the slides, so I'll leave these for you to review later. None of this content will probably surprise you. I'd like to reference my colleague, Dr. Alex Stewart from the HNE Menopause Hub for the content for these next 4 slides. CBT has some evidence to support it. ACT has some, next slide, please. ACT has evidence to support it in this space, certainly, particularly around promoting psychological flexibility and doing values-based work. Next slide, please. Dialectical behaviour therapy can be useful in helping women manage menopause symptoms, particularly managing irritability and shifts in mood. Next slide, please. And there is some emerging evidence for the use of EMDR for women with menopause. And my hospital is currently undertaking a research project on the use of EMDR in psycho-oncology, and this is one aspect of care we're hoping to gather some data on. Next slide, please. Here's a few tips from me just to finish up. I would suggest that it's always useful when you're working with a woman who is going to be prescribed endocrine treatment or has experienced treatment-induced menopause, to ask in your assessment, have there been other times in your life when your mental health has deteriorated after a shift in your hormones? For instance, when you had your onset of periods when you were younger, did your mental health decline then? Did you ever have PMDD? Have you ever had postnatal depression? When those things occur, we need to be extra aware. That indicates to us that this person is likely to have an impact on their moods from hormone shifts. That's important information to pass on to medical oncologists. Validating distress is important, but we need to be considered about pathologizing the menopause process. There are many cancer survivors undergoing treatment-induced menopause who do not experience problematic levels of symptoms. We need to support patients to increase their exercise. There's so many benefits to that in so many ways. We also need to support patients experiencing treatment-induced menopause to reduce their alcohol use. If that's of relevance, alcohol tends to have a bigger impact on women's moods when they're undergoing perimenopause or menopause. Next slide, please. Whatever we can offer to assist with managing the emotional complexity of the decision to stop or decrease endocrine treatments can often be of assistance. So supporting patients about how they participate in those conversations with their doctors can be very important. And there is evidence, I think there's firm evidence to suggest that when you have a patient in front of you who is presenting a range of mood disorder symptoms in the context of cancer care, and they also have disordered sleep, it's often useful to start by addressing the sleep. If you address the sleep first, you'll get more change on the other goals quicker than if you put it last. It's often a way to build rapport. Clients are usually happy to collaborate first on addressing sleep, improving sleep. And I think it's always important to make space in those conversations for fear of cancer recurrence, and how increased anxiety might be fueling fear of cancer recurrence, or how fear of cancer recurrence might affect how someone interprets their menopause symptoms as well. Next slide, please. Thank you for that. Oh, I got in just 1 minute over time, sorry. And like Coen, I'm very happy to have questions or discussion. Thank you.
Thank you, Sophia. So we really had these two very insightful discussions today about cancer care and, the aspects that I really overlooked. Sophia really helped us highlight these unique complexities of cancer treatment-induced menopause. And to be really honest, I had never even, it was not even on the back of my mind about how treatment could induce menopause and how that can also bring about things like brain fogs and mood disturbances. So these are things that is very new for all of us, I guess. And Mr. Coen also helped us understand this really pivotal aspect of fear of recurrence of cancer, which is in fact a very natural response for people who are going through this state of uncertainty, after all they have been through. So as he highlighted the whole concept about accepting, and how we as psychiatrists or psycho-oncologists can participate in that through our compassion and first giving them that space for open discussion. As I had just gone through his book a few days back, and I was discussing about fear of recurrence with a patient, and it was really difficult for her to express about that fear with her family. And after a very long session, she mentioned that she was really embarrassed to even say it out loud, that she was scared, of whatever is going to come through. So I think these two aspects that we highlighted today definitely are going to help us in our day-to-day work and to uplift the care that we're giving to the patients. And this also shows why psycho-oncology as a unit is so important in cancer care, and where psychiatrists and psychologists can play a very important role, in validating distress, which is, in fact, what affects the quality of life the most, even after treatment and even in survivors. So I think the session was really fruitful today, and we are really grateful to both our speakers. Now we can have some time for questions from the audience to our presenters. So we had already collected questions before our session had started. Maybe we can take question for Sophia, if she's already there. So
May I just respond to one of the previously submitted questions?
yes,
While we're
yes.
waiting. There was a very important question about, in terms of different cultures, what other ranges of intervention have been tried in psycho-oncology. I'd just like to comment from the Australian perspective. There certainly is decades of experience of trying different art therapies, different modalities of group programs. Where it sits currently in Australia is that post-COVID, people undergoing cancer treatment are reluctant to attend groups for fear of infection. And we find that groups most successfully run when they're pitched at people in survivorship. Most of the groups are actually run outside of public health services by cancer support agencies. In terms of alternative treatments such as focused yoga or art therapies, to be honest, I think the UK does it better than Australia. The range of programs that are offered in the UK through their Maggie Centre program is impressive. So if anyone's interested to see what range of programs might work, I would suggest you look there. Thank you.
Thank you. Thank you, Sophia. I think we can take one question for Coen as well. So do we have a question that you would like to answer?
Yes, well, I actually thank you, Sophia, for interesting presentation also. Was helpful. I also have a question for Dr. Rishav, which is also about the fear of cancer recurrence. Is, like Sophia was saying, the difference in culture and fear and how people experience fear and express fear. I think one of the things that our moderator just exampled about the importance of shame. There can be so much shame about fear and anxiety that you're not positive, that you're not, and because the prognosis might be good. So if there is shame, we need to address that first before we can actually address the fear actually itself. Now, the question which I have for Dr. Coralla is, in research, it seems that the numbers of people with fear of cancer recurrence in Asia is a little bit lower than in non-Asian countries. And I'm not sure why that is. In many Western countries where most of the research is, like Australia and the Netherlands and America and the UK, it seems a bit higher than it is in Asian countries. So Dr. Coralla, or our moderator, which name I have difficulty pronouncing, what do you think? Why could it be that in Asia it might be a little bit lower, the fear of cancer recurrence percentages?
Well, I think Dr. Rishav can answer that better than me. It's been working for a long time.
Thank you. Thank you everyone for a nice presentation. And this is something new for me too. I haven't explored this in this angle, like why the fear of recurrence is less over here. First thing is, I think one thing could be like people are a bit hesitant in Asian subcontinent to express their feelings. So the data that we have received might not be what it is actually they are going through. Like people might be hiding their emotions and not expressing their fear. One possibility could be that. The second might be because of the lack of awareness among cancer patients. You see, people see illness as something that comes and that destroys their life, and but once they recover, they don't expect it to reoccur because of lack of awareness. Because a lot of people over here, we had another question also, that why we are not able to, like, is it good to share about the cancer prognosis with the patient or not? Because in Asia, a lot of people who have like cancer, they are of elder age group and they are not made aware about their illnesses. Not to make them less anxious and give them less stress, because cancer itself is a very fearful thing for most of the people over here. It's like a death tag to most of the people. So they don't inform them. But once a person gets improved, then probably they have a lot of hope that this will not occur. And they are not so much aware about recurrence of cancer, how common it is. So probably that also might be, that lack of knowledge might also be causing less fear of recurrence. But this is just a speculation, I must say, and we need more evidence for this, more exploration.
Yes,
Thank you.
thank you. And I think I would also be interested in the last level, last step 5, accepting. I'm just wondering if people in Asia or in Nepal can sometimes be more accepting that things do not go the way they wish. In my country, the Netherlands, many people have difficulty with accepting that life often goes its own way, and often a way that we don't like. So this would be also one of my thinking, that perhaps in Nepal, we can also learn from, how to live with life as it goes, instead of thinking that we can control life fully. So thank you very much, Dr. Rishabh.
One last question, please, because I don't want to miss this. I got this message from NP. I don't have his name. For both the presenters, in your practice, are there specific red flag biomarkers or behavioral patterns you recommend clinicians look for during routine follow-ups? Probably she or he is asking for something that we need to just keep in mind while dealing with patients regarding fear of recurrence or any psychological distress.
Well, I can get the first one. Sophia can maybe get the second one. Of course, the distress thermometer is helpful in detecting some of the fear of cancer recurrence. It's not optimal. We can still, miss it with the distress thermometer. So to actually ask, and like I'm saying, sharing, many of my patients feel they have difficulty with getting optimistic again, even though they want to be optimistic, but their mind is not optimistic. They might be very worried about their body. Do you also experience these kinds of things? Now, this is opening the conversation, which is important. And the second thing is nonverbal expression of fear and anxiety. If people tense up if they speak about the topic of cancer or fear of recurrence, with the people who are very high on fear of cancer recurrence, you can see they tense up. They get like a hot flush. They might get, a little bit irritable, or they're gonna twist their body a bit. They find. So these are all signs for stress if you talk about these kinds of topics. And then you can say, oh, I see you move a lot here, but is this difficult? Is this a difficult topic for you to discuss? And then the next question would be, how would it be for you if we would discuss this topic? You're not even discussing the topic. You're just making comment on if we would discuss this topic. And then they might say, I'm afraid I would cry, and I don't want to cry. And then you have a topic already to talk about. So, Sophia, for you.
Thank you. I think one of the red flags for me is if the person has previously been very engaged and consistent in attending oncology appointments and then suddenly stops attending follow-up. Not so much with me. If they're not attending follow-ups with their medical oncologist, this is much more concerning. I also really appreciate the point Coen raised before about shame. The presence of shame, I think, is an indicator of concern. Also, if a person has zero tolerance for fearful thoughts, if whenever they have even the slightest fearful thought, they have brutal self-criticism, then for me, that's a red flag. Also, if they continue to hold as their goal that life should return to how it was before cancer. If they are not interested in adaptation, if their goal of intervention or behavioural change is to only wind back the clock, that for me is a red flag as well. That's what comes to mind for me. And also actually increased alcohol use. Thank you.
Well, I found a very interesting question, which I also want to ask. Richa Kharka, she's asked, how do you address existential fear or meaning of life questions?
Well, I think we should have a new webinar to address these questions. because these are very important questions, actually.
Yes.
You know, we also know that in studies there is a correlation between death anxiety and fear of cancer recurrence. So they, of course, you know, thinking about death, but also thinking about how to have meaningful life if you're more fatigued, how to have meaningful life if you are cognitively not as bright as before, and you might have lost your job, or you might not be able to be so clear thinking as before. So to actually, the most important thing is just to have conversation about these things. What is meaningful for you? When in the last 2 weeks have you valued your life the most? And then they might say, well, when I was with my grandchildren and I was helping them with this and this, I felt very meaningful. Okay, so actually that sense of being meaningful has connected with her, you know, sense of being a grandfather or grandmother, and we can then help them to have more of that. Sophia.
Thank you. I would add to that. I agree with everything Coen just said. And also that when those conversations go well, when those conversations are getting to an appropriate level of depth, the tone is often bittersweet. We need to make space in those conversations for people to name their loss and grief in order to be able to salvage or to find the values underneath that. So it's important as therapists that we don't take into that conversation an overly optimistic tone. We need to hold the space and allow the distress to emerge, because unless we get that, then we're not getting meaningful engagement, I'd suggest. But I absolutely agree, that's an entirely different webinar topic.
Thank you, Sophia. I know there are many questions that the participants might have. I think we can wait for another webinar and we can discuss further and ask more questions. So this session today was really, really helpful, and it was a very good discussion for all of us. So I think we can end the session today, and we will update about the next webinar soon, and we can take the questions that we've taken. Maybe we can answer that in our webpage later. So thank you, everyone. Thank you for your participation, and good night, good evening, good night.
Thank you.
Thank you.